Now, today's session is about surgical management of stress urinary incontinence. Again, it is a nice guideline published on 2nd April 2019. So this guideline talks about surgical management of stress urinary incontinence. What we have seen previously was a management of overactive bladder, stepwise management. I hope the management of stepwise management of overactive bladder was clear. Now we will talk about stress urinary incontinence. Okay, surgical management. So before you pose the patient for surgery, you have to do extensive counseling. Okay, so there is a PDA, that is patient decision making aid. Okay, so patient decision aid that you need to offer. And this is as per the NICE. Okay, so this patient decision aid, what we need to discuss, what are the available surgeries, what are the risk and benefits, uncertainty of long-term mesh complications, anesthesia, recovery, and hospital stay we need to discuss, social and psychological factors we need to take into account, and we need to see the choice irrespective of local availability. Okay, so this is what is the most important is a pre-surgical counseling, and we need to offer all kind of surgery which are available. We need to discuss the risk benefits. If it is a mesh, we need to discuss the long-term complication, especially they are uncertain. Okay, so this is all we need to discuss. Then options after failure of conservative management. Initially management is a conservative, but if this conservative management is failed, then we will offer the surgeries such as colposuspension, which may be open or laparoscopic, autologous rectus facial sling, and third is a retropubic mid-urethral mesh sling with additional mesh related conditions that we will discuss in the next slide. So three types of surgery we are going to offer for stress urinary incontinence. That is colposuspension. It may be open or laparoscopic. Okay, and open as well as laparoscopic, the outcome is same. Okay, but here then which one you will choose? That is the one laparoscopy has got in general less duration, what you can say, the patient can resume the activities very early. Okay, so you will select the laparoscopy, both options are given, but practically speaking, as far as outcome of the surgery is concerned, the for SUI both are almost equally effective. Okay, so next surgery is autologous rectus sling, and third one is a retropubic mid-urethral mesh sling. Okay. So bulking agents is another option, but they will be offered only if other surgeries are not suitable or unacceptable. Then when we are offering the bulking agents, what we need to discuss? We need to tell that these are permanent material, may require repeat injections, less effective than major surgery, and there is a limited long-term data. Provide written information with respect to material, manufacturer, and surgeon details that we need to provide. Okay, if it is a bulking agent. Now, mid-urethral mesh sling, if that is the option, in that particular case, counsel that mesh is a permanent implant, complete removal may not be possible, and provide written implant details. Use type 1 macro porous polypropylene sling, okay, mesh sling. Prefer utropubic, avoid transobturator except in specific clinical indications, and do not use top-down or single incision slings except in trials. Here they ask you the material for mesh sling, mid-urethral mesh sling. It is a type 1 macroporous polypropylene. Okay, so this you should remember, type 1 macroporous polypropylene sling. Okay, the material which is used is a type 1 polypropylene material, and approach is a retropubic approach. Then artificial urinary sphincters offer only if previous surgery has failed, and provide post-operative follow-up and easy access for review. Then the procedures not recommended. For stress urinary incontinence, do not select options such as anterior colporrhaphy, needle suspension, paravaginal defect repair, porcine dermis sling, or MMK operation. Okay, that is Marshall-Markenti-Kratz operation. So these procedures for urinary incontinence or stress urinary incontinence are not recommended. Anterior colporrhaphy you will select when there is a anterior prolapse as such, not for the SUI. Okay. Then follow-up after surgery. Remember, all follow-up and the duration after which you are going to call the patient. Okay. After SUI, the follow-up is at 6 months for all SUI surgery. For medicine, it was a 4-week review. Okay. Here, it is a 6 months review. And for complications, it will be 3 months review that we will see subsequently. Okay. Follow-up after surgery, follow-up is at 6 months for all SUI surgery. After midurethral sling, you have to perform the vaginal examination to check for mesh exposure, ensure access to further referral for recurrent symptoms or mesh complications. So if it is a mesh complication, you have to refer the patient to the specific team. And for failed primary surgery, refer to the regional MDT or provide symptom management if she declines further surgery. Okay, so here comes the role of regional surgery if the primary surgery has failed. That also we have seen in the initial slides. Okay, so that finishes the management or the surgical management of the stress urinary incontinence. Okay, thank you.